Hello, this is Stacy again. So here's part two. We're going to go over the pathology of the intestines, 2 by Campbell, and then also, 2 and 3, and then the farm of GI motility by Babos. So let's start out with inflammatory bowel disease. Okay, so IBD, we've got, when we think of disease versus or like when we think of IBD versus IBS, D stands for disease, and that's Crohn's disease and ulcerative colitis. So that's the two that you should think of. IBD has a tangible cause, whereas like IBS, irritable bowel syndrome, does not. So risk factors would be Caucasian, Jewish, smoking, urban environments, family history, and NSAID use. Symptoms usually start young, but the peak diagnosis is in the 30s, and then there's another peak at around 60 to 70. It's important to know about IBD, not just because it's on your exams or, these can be really terrible, hard diseases to deal with as the patient and for your patients, but also it puts them at an increased risk of colon adenocarcinoma. So I would make sure that I would know that it puts these patients at risk. So bacterial antigens have access to APCs during the via the damaged epithelium. They secrete IL-12 and 18, which go to Th1 differentiation in Crohn's, and then in UC, IL-4, remember, promotes that Th2 differentiation. So Th1 with Crohn's and Th2 with ulcerative colitis. So let's look at the differences between these. So the location for Crohn's disease would be any area of the GI tract. The most important area would be that terminal ileum. But these patients can have it even they can have lesions even in their mouth. So if you hear of a patient or see a patient, they've got small bowel and they've got maybe even mouth lesions, start thinking about Crohn's disease. Whereas ulcerative colitis is mostly the colon and the rectum. So if you see rectum, it could be Crohn's because it can be anywhere in the GI tract, but most likely it's probably ulcerative colitis. The depth is also different. So Crohn's disease goes all the way through. It's transmural, where ulcerative colitis is only the mucosa and submucosa. The intestinal wall is thick. It has strictures, deep knife-like ulcers, and a creeping fat with Crohn's disease. With ulcerative colitis, it's less. It has superficial ulcers. So they both have ulcers, but remember, it only goes through the mucosa and submucosa in ulcerative colitis. And it's thin and dilated. If we look at imaging, we see these cobblestone or skip-like lesions in Crohn's disease, and in ulcerative colitis, think of lead pipe. There's loss of haustra and pseudopolyps. So we'll look at some pictures later on. So histology, there's non-caseating granulomas in Crohn's disease, but we do not see that in ulcerative colitis. For our antibodies, we've got a positive ASCA, ASCA. I remember being tested, I'd remembered what all of these things were, and I knew what ASCA was. I knew it was positive in Crohn's disease, but I didn't actually know what the word stood for. So make sure that maybe you memorize it's ASCA, but make sure you look and know that it's anti-Saccharomyces cerevisiae. And then in ulcerative colitis, you've got a positive P-ANCA or MPO-ANCA. Associated diseases in Crohn's disease would be erythema nodosum and pyoderma granulosum. In ulcerative colitis, primary sclerosing cholangitis, and that's going to be important, and we'll look at in the next block, third block. So complications with these is going to be fistulas or strictures, and then in ulcerative colitis, it's toxic megacolon. So response to surgery is poor in Crohn's disease, but it's pretty good in ulcerative colitis. But both of these conditions, patients do sometimes have surgery. Okay. I'd make sure that I knew the difference between these, and this is a really great slide to like go back and forth and know the differences. So here's Crohn's disease. We had talked about some skin changes. So we've got erythema nodosum and pyoderma gangrenosum. So the pyoderma, it sort of has that like nodule that kind of is ulcerating, kind of has a purpley greenish appearance to it. Erythema nodosum are like raised tender nodules on the shin. Genetics are going to be NOD2 polymorphism. And then complications, they have an increased risk of blood clots, DVTs, and PEs. And then we also have malabsorption. Fistulas, like we mentioned, strictures and abscesses. Fistulas is pretty important to remember, and that if you hear that a patient has a fistula of the colon, start thinking about Crohn's disease. Here's our histology. We said that there was non-caseating granulomas. And you can look in the first picture, we've got like sort of a haphazard crypt organization, as we can see here, instead of these pretty crypts. Right here, we've got this like big knife-like transmural fissure. And here is our, right here is our granulomas. So we know that's Crohn's disease, no granuloma in ulcerative colitis. Okay, here's UC. It is infectious enteritis, stress, or smoking can trigger an initial episode of UC. So we've got red granular broad-based ulcers, as shown here, and pseudopolyps. So like on a colonoscopy, they may think, oh, here's a polyp, but it's not. It's not a true polyp. And then here we've got inflammatory infiltrates and crypt abscesses, but no granulomas. So we can see ulceration here. Okay, so how do we treat it? So we're going to initially treat with steroids, and then also if a patient has a relapse, we would also go to steroids as well. Our drug of choice to begin with would be budesonide. It's got a local release, and so systemic effects are pretty low, which is good. Prednisone would be another option. However, as we've talked about steroids in many classes, hypertension, it can result in decreased fertility, osteoporosis, increased glucose, or adrenal insufficiency with steroids. And then hydrocortisone would be like a topical or local effect. 5 ASA compounds, so like aspirin-like compounds inhibit IL-1, TNF-alpha, and the lipooxygenase pathway. So examples of these would be sulfasalazine or mesalamine. These are good, these are good compounds that I would make sure that I would know in the treatment of IBD. There's also like immune modulators that are used to treat like or resistant to steroids, but remember it's like bone marrow suppression. So like azanthropine, remember, like, don't take it with allopurinol because it can impair the breakdown and cause those toxic levels. Methotrexate is another immune modulator that's used in like rheumatoid arthritis, in other autoimmune disorders, and it inhibits hydrofolate reductase and inhibits tubular secretion. Okay, so that was IBD, Crohn's disease, and ulcerative colitis. And now we're going to talk about irritable bowel syndrome. Okay, so irritable bowel syndrome, or the spastic colon, doesn't have that structural organic abnormality. It's really an unknown cause. So you might see like on TV, they'll call it like IBD or IBC or IBA, or I'm sorry, IBSD, IBSC, and IBSA. And so what the letters at the end are like diarrhea, constipation, or alternating patterns. Things that do not happen with IBS are rectal bleeding, nocturnal or progressive pain, weight loss, anemia, inflammatory markers, or electrolyte issues. This is not with IBS. It is, start thinking then about like IBD or something else. Non-pharm treatments are going to be like diet modification, or like don't eat gas producing food, lactose, maybe gluten. And sometimes they think that it's associated with maybe anxiety, so maybe a SSRI. And then for OMT, to tie that in, superior mesenteric ganglion release helps IBS. So some other treatments are going to be to help with against contractility. So allosterone, which is a 5-HT3 antagonist, that can work right there. Like it can help with IBSD, and work right there at the GI tract. Linaclotide is a GCC antagonist, and it increases CGMP to help treat the constipation. Another one to help treat the constipation form is lubiprostone. So prostanoid derivative, and then antispasmodics like dicyclomine, hylocyamine, or glycopyrrolate are other examples. So treatment for diarrhea, a lot of people think of like Imodium, which is like loperamide. It's a mu agonist with poor CNS penetration. It just decreases the transient time, increases anal and sphincter tone, and has that anti-secretory effect against cholera and E. coli, which is kind of interesting. It helps treat traveler's diarrhea. Diphenylxylate and atropine are anticholinergic. So think about all of our like dried mouth, blurred vision, all of our like anti-muscarinic, or like slud things. And it can, this can help treat like overdose constipation. So if a patient had taken a bunch of opiates and had constipation, as well as toxic megacolon. So secretory diarrhea can be treated with octreotide, which is basically somatostatin. It inhibits 5-HT and GI peptides, and it also treats secretory diarrhea from those hormone-secreting tumors, and helps short-term with nausea, bloating, and injection site pain, but long-term short-term, it may cause nausea, bloating, injection site pain, and long-term gallstones or hyperglycemia. Okay, more treatment would be like for laxatives would be Salium, methylcellulose, or calcium polycarbophil. Surfactant laxative would be like docusate, laculosorbitol, and mannitol. Semi-fluid stools would be like stimulant irritate laxative. It helps promote accumulation of water. Would be like bisacodyl or senna. And then watery evacuation would would be like, you would want osmotic laxatives like PEG, polyethylene glycol, or sodium phosphate. So prokinetic agents would be like D2 receptor antagonists like doperidone or erythromycin. Other agents, I don't know how much these were like super important, but like with bile salts, ursodeoxycholic acid, and it helps dissolve gallstones. Anti-fluctuants, Gas-X, which is simethicone, Synclidade, and then dexaglutamide, or they work on CCK. So here is my, like, I think that it sort of helps. This is what I found to be most important. So azanthropine 6-MP, remember, it can cause bone marrow depression. And then remember, it has that drug interaction with allopurinol. Aminosalicitates are effective depending on high concentrations. Like azo compounds would be sulfasazazine. And then like pentasa delivers ASA to different segments of the colon. And then budesonide has that less systemic effects to the colon IBD. Okay. So now pathology of intestines 2, and we're going to look at ischemic bowel disease. Or 2 and 3, I guess. So watershed areas are the most affected. You have to remember back to your anatomy days. So the splenic flexure and the rectosigmoid junction are some of these watershed areas, and you can see it sort of in the picture right here. So the etiology is going to be an arterial occlusion, most likely like SMA. So if we think about what comes off of SMA, we have, I remembered it as like M, R, and I. So we have middle colic, right colic, and ileocolic. And then remember that we've got like our, like, so between our transverse colon and our descending colon would be the splenic flexure. And then the rectosigmoid junction is going to be like at our sigmoid, going out. And that is from comes off of our IMA, is what blood supply that is. So chronic ischemia is due to like mesenteric atherosclerosis. So really just think about like you'd have chronic ischemia anywhere. But acute ischemia is going to be because of some different things. Like non-occlusive ischemia is like hypoperfusion. So if we have heart failure, shock, dehydration, vasopressors, or vasoconstriction, it can cause acute cause of ischemia. Venous thrombosis is uncommon, but it can also cause ischemic bowel disease. And then just any systemic vasculitides. So the path is going to be, there's going to be initial hypoxic injury to the epithelial cells lining the intestine. Then there's going to be a reperfusion injury. And remember, like when we were in cardio, reperfusion injuries are really the most damaging. So we've got neutrophils that are going to infiltrate, and then we've got our inflammatory mediators bringing in those free radicals. There's mucosal and then mural infarction, which includes, does not include the serosal involvement, and it can develop collateral circulation or just get, or it'll like start causing a worse infarct if not corrected. And then a transmural infarct would be the next step. That's a very sharp demarcation between normal and infarcted bowel. Okay, so risk factors are going to be cardiac disease. So think about like heart problems, like cardiac disease, anything that's like involving our like arterial circulation. PAD, hemodialysis, vasoconstrictive meds, thrombotic conditions, inflammation, infection, hypovolemia. The patient is going to have pain out of proportion to the exam. At the very, very last stage, they may have current jelly stools. That's something that you would probably see in your exam. So think pain out of proportion, current jelly stools, ischemic bowel. They can have a normal mild distension and no peritoneal signs. And actually, like in third year when I was in general surgery, they would ask me like what you would see with an ischemic bowel. And I always said current jelly stools. And they always told me, no, that's wrong. Because they're like, well, it's right, but like you're not going to see that on your patient, because at that point when you're seeing that, it's almost too late. But just know it for the test. So imaging, CTA is preferred so we can see the blood supply, but a colonoscopy can also be used. So treatment, use of vasopressors, anticoagulation, and antibiotics. And then if it's not reversible, surgery. And so they may have to take out that portion of the bowel. Okay, histology is going to be neutrophil infiltration within hours of the reperfusion, like we had talked about, and we can see that here. Lots of neutrophils. And chronic would be like atrophic epithelium with fibrotic lamina propria. All right, so that's that. So now we're going to go to celiac disease. So celiac disease is very important to know. It's also called celiac spruce. Make sure you remember that it's not tropical spruce or gluten-sensitive enteropathy, it's also called gluten-sensitive enteropathy. So there's an immune reaction to alpha gliadin peptide, and I would know that for sure. And so gliadin induces IL-15 expression, which signals that CD8 expression to express NKG2D to bind into MIC-A on distress enterocytes. So it interacts with HLA-DQ2 or 8. So I really don't know, but like I had one tutor one time say like she thought of the Dairy Queen every time she saw that. So like even if you're age 2 to 8, you like to go the Dairy Queen. I don't know if it helps you remember it, but and you can't eat a hamburger because it'll give you diarrhea because of the gluten. I don't know. Anyways, these patients may present with dermatitis herpetiformis, which you learn about also in derm, which is that like itchy, blistery skin that looks very similar to herpes but isn't. It's really due to anti-gliadin IgA cross reactivity with epidermal transglutaminase on the skin. And it's also associated with type 1 diabetes. So if you see dermatitis herpetiformis, think celiac disease. So when we screen, the best serology would be an anti-TTG. So let's say we're on a test and we think, okay, this patient has celiac. And it says, what is the best screening choice? And it has anti-TTG, anti-gliadin, anti-endomysium, and it has like some other thing that goes with another, like goes with something else. Make sure that you know that anti-TTG is the best, but also know that you can diagnose it with anti-gliadin and anti-endomysium. And I'm saying that because I do think that I've had a test question or a practice question somewhere that asked which one was the best for celiac disease, serology-wise. And then I also have had multiple questions that didn't have anti-TTG. They just had gliadin or endomysium. And I had to know that that was a serology associated with celiac, even though it wasn't the best because TTG wasn't available. So just know that all of those are serology tests, but anti-TTG is the best and preferred. Confirm with an upper endoscopy with a small bowel biopsy, and you'll see mucosal inflammation and villus atrophy. It's the one that you'll see, villus atrophy, crypt hyperplasia. There's loss of villi, and that's really important to know as well. Treatment is going to be a gluten-free diet, replace vitamin losses, and monitor for osteopenia. There is an increased risk of enteropathy associated T-cell lymphoma and small intestinal adenocarcinoma. So remember, we had adenocarcinoma that was associated with our IBDs, our UC and Crohn's. And then with celiac disease, they could get a lymphoma or a small intestine adenocarcinoma. So tropical sprue is celiac-like disease found in developing countries with poor sanitation and hygiene. I wouldn't worry about that. Okay, Whipple's disease, which this is like, I don't know why. This is like my favorite. I have no reason to think this is my favorite, but it is. It's caused by gram-positive bacilli. And in the vignette, you'll see a Caucasian male, 30 to 50, with malabsorption, diarrhea, and weight loss. They do a biopsy, and it shows PAS stains with positive granules. Or it'll say there's a PAS stain, and then they show you this picture that I highlighted in green. Honestly, there's not that many things like GI-wise. Really, I can't think of anything that shows up PAS positive and looks like that. So if you ever see that on a test of any sort, the answer is Whipple's disease, and move on. You don't even have to like really read the question. If it says PAS, it has this picture. It's bright purpley, or it's bright pinky purple. That's Whipple's disease. Okay, diverticulosis. So people get confused with diverticulitis, diverticulosis, diverticulum. So diverticulums are these like little blind pouches that are either congenital or acquired. Congenital ones have all three layers of bowel, but acquired lack that attenuated muscularis propria. Diverticulosis is the presence of these diverticulums. Usually it's located in the sigmoid colon or in the right in Asia. Diverticular disease are symptomatic, bleeding, or infection. And diverticulitis is inflammation of the diverticulum. You will see multiple patients that will tell you that they have diverticulitis. They do not have diverticulitis. They have diverticulosis. So at one point, they probably had an inflammation infection and had to get treated. But if they don't currently have an infection, they don't currently have diverticulitis, they have diverticulosis. The most common cause of blood in the stool is diverticulosis. And that's important to know. And you probably will see that on boards. It will ask you what the most common, it may be the test. It will ask you the most common cause of bleeding, of blood in the stool. And the most common cause is diverticulosis. Why do we really care? The problem is, if you see blood in the stool, you have to assume and make sure that you rule out cancer, colon cancer. However, it's probably not colon cancer. It's probably a bleeding diverticula. So just so you know that. Another like little side thing, in Asia, if a patient presents with like right-sided pain, usually anywhere else, you think, okay, this could be appendicitis. However, in Asia, it could be diverticulitis. So, well, fun facts. Mean age is usually 60s. So on a colonoscopy, you see these, it kind of looks like Swiss cheese. You see these extra little holes. And sometimes it's confusing. So they'll be like going down, and and I've helped with colonoscopies, and like you think you're going in the colon, it like gets smaller, and sometimes you can't see if they've not cleaned out well, and you accidentally go into one of these little diverticula instead. So on imaging, you're going to see bowel wall thickening and fat stranding. And if they have diverticulitis, you are not going to want to do a colonoscopy because you could rupture one of these. So like make sure that you know that. And then our antibiotics are going to be Cipro and metronidazole. Oh, clear liquids and fiber. So the thing about fiber, and this helps sort of like prevent it. So a lot of people say, well, I can't eat nuts or seeds because I have diverticulosis, or they say diverticulitis, but it's diverticulosis. Well, it's not exactly true. So yeah, so it used to be thought that you couldn't have nuts and seeds if you had diverticulosis, but they actually did a study and they found that people with high fiber diets actually prevent diverticulitis, because the whole thing is that their stools aren't moving and they have like constipation. So actually, like nuts and seeds are actually better for diverticulosis, to prevent diverticulitis. Meckel's diverticulum is that blind pouch located in the distal small bowel, and it's usually a congenital abnormality, and it's a failure of the omphallomesenteric or vitelline duct involution. Usually it is asymptomatic, and it can cause that SIBO and result in B12 deficiency or anemia. It can also have ulcers, bleeding, and obstruction. And that like telescoping of the bowel can also be associated with Meckel's diverticulum. And when you see it in a vignette, it usually has the rule of twos. So it's in 2% of the population. It's 2 inches in length. It's 2 feet proximal to the ileocecal valve. And it is, so it's in usually like at the ileum, and there's 2 types of tissue associated, pancreatic and stomach tissue. Okay, pathology 3 with Wang. So these are the intestinal tumors. So we've got polyps. They're mass producing above the colonic mucosa into the lumen. And then we've got types of polyps. So I thought that, I don't know, for some reason, I thought this was like really interesting. And it's like a good thing to remember, because in like general surgery or a GI rotation, they'll ask you about this as well. So hyperplastic are the most common polyp in patients 50 plus. And it's usually rectosigmoid due to a delayed shedding of surface epithelial cells. And elongated glands and crypts have serrated or a star-shaped appearance. And you can see that in the top pictures. Inflammatory ones are mucosal ulcers, and they have marked inflamed or edematous mucosa. And then neoplastic are going to be adenomas. Okay, so here's our types of adenomas. So tubular, villous, and sessile serrated. So tubular ones, they look like little tubes, and they are lined by cells with elongated hyperchromic nuclei. Our villous ones are going to be a little worse, and they've got elongated granular structures covered with cells with elongated hyperchromic nuclei. And then our sessile serrated are going to be the worst. They're high-grade dysplasias, and the genetics are going to be microsatellite instability mutations and CpG methylation. So I would know that for the genetics. I would know sessile serrated is the worst and tubular is the best type of adenoma, or like it's the least lowest grade dysplasia. Intramucosal carcinoma. So here's what looks like a malignant granular cell. And this is that malignant change confined to the mucosa there. So juvenile polyps are most commonly seen in childhood, and that's why they're called that, but they can actually be seen at any age. And it's a loss of function mutation of SMAD4 or BMPR1A. I think SMAD4 is probably the most important. These kids usually have congenital malformations and digital clubbing as well. They have an increased risk of GI and pancreatic adenocarcinoma. And so we can see these big cystic dilated glands. Peutz-Jeghers Syndrome, super duper important. This is important for derm and GI. So melanocytic mucocutaneous pigmentation. So if you see a picture of a mouth and it's got like lips, oral mucosa, genitalia, digits, palms, or soles, and it's got like pigmentation lesions like in this picture, then think Peutz-Jeghers syndrome. And it is a heterogeneous loss of function mutation of STK11. So know that. Histologically, it's got these Christmas tree apparent lesions, these broadband smooth muscle fibers that are thicker centrally. So you can kind of like see, kind of looks sort of triangle like a Christmas tree. Familial Adenomatous Polyposis, FAP. This is a mutation of APC. Remember all the way back to MFM1. It creates, there's also the MYH associated one as well, which is the DNA mismatch repair. So usually we think of like the mutation of APC with FAP. It's hundreds, thousands of intestinal polyps, fibromas, and epidermal cysts. And remember that these people with FAP, they have a higher risk of cancer. So they start getting colonoscopies at a really young age. Lynch syndrome also gets colonoscopies at an earlier age. It's also called hereditary non-polyposis colorectal cancer, so HNPCC. It's the most common hereditary colorectal carcinoma syndrome. And there's going to be mutations in MLH1 and MSH2. It's that mismatch repair. Colorectal adenocarcinoma. The clinical presentation varies with the location. So on the right side, think about like what happens anyways on the right side of a person. We've got our small bowel. So anemia, weakness, fatigue, weakness and fatigue go with anemia. So it bleeds more on the right side. On the left side, it's, our stool is more formed. So at that point, we've got a change in bowel habits, diarrhea or constipation, and maybe they even get better with GI issues. Risk factors are going to be IBD or diet. And then the pathogenesis is going to be like an APC mutation early in that neoplastic process or DNA mismatch repair. Know that there's increased CpG island methylation. And remember that this is associated with our IBDs. So here we can see these irregular glands infiltrating the submucosa. And here we can see this atypia of like here. So it looks normal there. And then here's this atypia with necrosis. We can see that it's black and then also active mitosis as well. There's serosal puckering. And then like here's this like huge lesion. Here's this apple core. So like if you think of like somebody eating an apple, so like here would be the apple and then they like eat down. So it's basically just making like the like pencil thin stools. Mucinous colloid adenocarcinoma has the signet ring cells in less than half of the tumors. It's got that gelatinous appearance of a tumor, and so you can see these big like mucinous glands pools. So signet ring, like right here. So if you think of like sort of like the traditional class ring, you've got like this, like here's the part of the ring, and then there would be like the band. If the signet rings are like in greater than 50% of the tumor, then it's considered signet ring cell carcinoma. Again, if it's less than 50%, it's located in some, but not more than 50, then it's just, and they've got these mucin pools, and it's mucinous. They still may have mucin pools present, but the majority is going to be signet ring in the pathology. Carcinomas of the anal canal are usually associated with HPV and squamous cell carcinoma. There's going to be a plexiform pattern with palisading cells. And you can see right here, we can see this squamous cell carcinoma in that like trabecular growth pattern right here, with like the periphery is palisating. Pseudomyxoma Peritonei it's actually a clinical syndrome. It's not a histological diagnosis, but it is a associated mucinous tumor, usually of the appendix. So I just remember this was like the appendix tumor, Pseudomyxoma Peritonei. The other tumor that is associated with the appendix that has symptoms. So like this is the one that's like, okay, it's kind of mucinous looking appendix. And then tumor that actually has symptoms. It's got these like nested patterns. They've got like high levels of 5-HIAA, and then neuroendocrine markers like chromogranin, synaptophysin, CD56. It's a well-differentiated tumor that secretes serotonin. So high levels of serotonin. They usually need to have, so it's important to know, these patients probably have no symptoms. However, when you're on a board exam, they want to like tell you that this is what this is. They can tell you in multiple ways. They can show you this histology slide, and you have to know that that's a carcinoid tumor of the appendix. And then it might ask you like, how do I, what's a marker for that? So then you would need to know chromogranin, synaptophysin, or CD56. Or they can have this carcinoid syndrome. This syndrome usually has to have liver metastasis. So if they have the tumor, it probably isn't going to have carcinoid syndrome, even though it's a carcinoid tumor. It has to go to the liver for them to have these symptoms. So they may have like basically syndrome, like symptoms of serotonin syndrome, flushing, or like tyramine reaction. Flushing, like participated by alcohol, blue cheese, chocolate, red wine, exercise, as well as watery diarrhea, tachycardia, hyper or hypotension, and then bronchospasm. They also could have a niacin deficiency, that pellagra, scaly rash, and isolated right heart involvement. I think that this would be important to know that they can have pellagra or right heart involvement, and then that flushing is associated with carcinoid syndrome if it does attack the liver. Treatment is going to be somatostatin and analog octreotide. Okay, and so next you will the next video will be about the pancreas and biliary tree and the clinical aspects of this by the two professors here.